Dear colleagues, ladies and gentlemen, welcome here at ASCO GU in San Francisco for an update on advanced and metastatic renal cell carcinoma. It is my great pleasure sitting here with you, Laurence, Professor Laurence Albigès from Paris, a medical oncologist, and to chat with you about metastatic renal cell carcinoma. My name is Axel Merseburger. I'm a urologist from University of Lübeck in northern Germany as we know, we are connected within the EAU guidelines group, and I'm always learning so much from you. So please, if you could allude a little bit on what we've learned here at ASCO GU on the topic of metastatic RCC. So a question from colleagues and residents always come, do we need to risk stratify in 2020 according to HENG and MSKCC criteria?
Well, thank you, Axel, for the invitation. The short answer is yes. We do have to pay attention to our IMDC classification, so it helps us in two ways. It helps us to assess the prognosis of our patient, meaning their life expectancy, but it's now very important also to have this information in order to properly select our treatment strategy in first-line metastatic setting. Why is that? Well, if you look at the guidelines, both ESMO or EAU guidelines, for instance, you can clearly see that you have different standards now, depending on our IMDC risk classification. In patients with good risk disease, you want to favor a strategy of VEGF plus immune checkpoint. So namely, a combination of axitinib plus pembrolizumab. While in patients with IMDC intermediate and poor, meaning having at least one poor risk feature, we have two new standards. Nivolumab plus ipilimumab, a combination of immune checkpoint, or axitinib plus pembrolizumab, here a dual approach of VEGF inhibition and immune checkpoint inhibition.
Okay, thank you. So looking back to the guidelines 2015, we have Pazo and sunitinib approved as first-line treatment. Do you still see patients that you would just treat with monotherapy nowadays?
Well, this is a very important question. So these agents are still within the guidelines as option. We have two situations. We have some countries that are not yet have access to the combination because of reimbursement purpose.
Yes.
And so here we, of course, have to use single-agent TKI in this disease that is highly driven by VEGF. But there is an open question in patients with good risk, where we do know that the disease may be driven by this VEGF need of inhibition. And for the moment, given the data that we've had in combination, I would consider that a combination of axitinib plus pembrolizumab, so VEGF plus immune checkpoint, should be the new standard.
Okay, so knowing this and knowing the difference in the sequencing, like in Ipi-Nivo, you are done after 4 cycles of Ipi and then just have nivolumab, where in Axi-Pembro, for example, you have continuous combination treatment with different side effects, different adverse events to say. So is it just a Pepsi or Coke decision and both work? We both have seen overall survival benefit compared to sunitinib, but what would be your first line choice for the patient, or what the factors accounting for? Is it maybe also the tumor type, like thinking of papillary versus clear cell? What is your first line choice?
Well, there's many questions here. So once again, we are in the situation of patients with intermediate and poor risk. And here we have two new standards. So your question is, how should I decide for patients with clear cell? And I'm going to start with clear cell. We don't have any head-to-head comparison, meaning I cannot tell you which one is superior to the other. What we do know is that both of these regimens have demonstrated overall survival benefit over active agent as sunitinib. I think this is something that depends on, of course, access to both of those combinations, once again, in terms of reimbursement, in terms of patient profile, but also in discussing with the patient. So as you've explained, we don't have the same pattern of toxicity. And in one case, with the combination of immune checkpoint, we may have early on toxicity that are immune-related toxicity. But we clearly see a good quality of life in patients treated with nivolumab plus ipilimumab. And we also have, for this combination, long-term data. And here at this ASCO GU meeting, we'll have the 42 months follow-up from the CheckMate 214 study, which clearly demonstrated in the long run that the combination of nivolumab plus ipilimumab is associated with great overall survival benefit and great complete response rate, as well as benefit in terms of progression-free survival. So we have very long-term data with the nivolumab plus ipilimumab combination.
And according to my knowledge, no new safety signals out of this update.
Absolutely.
Okay.
What we do know from this combination is the vast majority of toxicity, immune-related toxicity, occurs within the first 6 months.
Okay.
With regard to axitinib plus pembrolizumab, we have a shorter follow-up. I agree with you that the VEGF-driven toxicity may be a challenge here, especially diarrhea or fatigue, or also liver enzyme elevation. And so with regard to this combination, I really feel that we have the VEGF backbone that may be associated with some degree of toxicity, which in the long run can be challenging for the patient.
Okay.
But in this combination, one of the strengths is the response rate. We have almost 60% response rate, 59% response rate. So it's a good combination to achieve strong partial response.
Thank you, thank you. So having you here and knowing your expertise in patients that are very difficult to treat, for example, with brain mets or different tumor entities like papillary, what would be your 2020 recommendation after ASCO GU now?
So at this ASCO GU meeting, we'll have data from the Javelin trial about brain mets patient. You have to understand that we have very few prospective data in patients treated with brain metastasis with this combination. So the Javelin trial is among the first one to report on the activity of a combination in patients with brain mets. What is being reported is response rate and PFS in those patients, limited number of patients. I think the take-home message is that patients with brain mets have a poor prognosis. We see a response rate that is in favor of the combination over sunitinib single agent, but clearly there is an unmet need for patients with brain mets, and as medical oncologists, we need to don't change the dogma and have focal approach, meaning like stereotactic radiation therapy to the brain, and systemic treatment as efficient as possible, and if possible, combination strategy,
No, really good point. I mean, you mentioned the radiation therapy. I've always learned, like years ago, that RCC is not really responding to radiation, but we have had a lot of discussion now and also presentation by Tom Powles showing the activity of radiation, so you probably have to consider. So after IO or IO-TKI first-line treatment, so what comes after IO? The big question. In my head, sometimes I always hear this HIF-2 alpha, or do you have other ideas what to best treat, or what is the best next substance or treatment we can offer our patients with this advanced disease?
Well, I have two messages to answer your question. First, in terms of treatment sequence, in terms of strategy, in a patient who failed a combination of immune checkpoint, IO, I want to offer VEGF inhibition. In a patient who failed TKI plus IO,
so make it clear, VEGF inhibition doesn't matter which substance.
Well, I think really here we need to go on the VEGF axis inhibition. We don't have data to support one drug over the other. While in patient with a VEGF plus IO strategy, you want to go for another VEGF inhibitor. And cabozantinib may have its role here as a broad spectrum VEGF TKI, but once again, we don't have prospective randomized data to answer which agent we would like. So you asked me about HIF inhibition. I think it is great that we now have HIF inhibitors. They clearly can play a strong role in RCC, given that it's exactly targeting one of the biological subset of this
Nobel
disease.
Prize awarded,
yeah, absolutely. So we want to target HIF axis, and we now have HIF inhibitors. Two take-home message from the data being presented here. First, the safety. Clearly, the HIF inhibitors that are available now seems to have a good safety profile, and therefore we can already think about the next step in terms of combination. And the second is, of course, activity. So we have 24% response rate But what is interesting in Tony Schwery's presentation is the response rate in patients with good risk that is higher. And we do know that this is the population that may have some degree of VEGF-driven disease where you really want to target the HIF axis. So I really feel that we need to have this agent in our radar in the future.
Okay. And do you also see an indication in first line or some combination, or what would be the ideal partner? I know a very spectacular now. I mean, it's very, very new and something for the future.
Yeah, for the future. I mean, we don't have the answer to your question. We want to combine this HIF strategy with an immune checkpoint, obviously.
Okay. Thanks a lot. So, thank you. Thanks a lot for joining us here for this activity. Laurence, I really, really thank you for all your expertise, and I know when I have a question whom to call. Thanks a lot. Thank you.